DVT. DVT stands for deep vein thrombosis. It is a condition in which a blood clot forms in a deep vein, most commonly in the leg, calf, or thigh. Through it can also occur in the arm or other deep veins. Symptoms: a DVT may cause swelling in one leg or arm, pain or tenderness, often described as a cramps or soreness, warm in the affected area, red or discolored skin, enlarged veins that are visible. Some people have no symptoms. Why it's serious? The biggest concern is that part of clot can break off and travel to the lungs, causing a pulmonary embolism, which is a medical emergency. Symptoms of a pulmonary embolism include sudden shortness of breath, chest pain, often worse when taking a deep breath, rapid heartbeat, coughing up blood, feeling faint or collapsed. If these symptoms occur, seek emergency medical care immediately. Risk factors. Things that increase the risk of DVT includes long period of sitting, such as during long fights or car rides, recent surgery or hospitalization, injury to a vein, cancer and some cancer treatments, pregnancy and the weeks after childbirth, birth control pills or hormone replacement therapy, smoking, obesity, older age, a personal or family history of blood clots, certain inherited clotting factors disorders. Treatment. The treatment includes usually blood thinning medications, anticoagulants to prevent the clot from growing and reducing the risk of pulmonary embolism. In some cases, clot dissolving medications or procedures to remove the clot may be needed. If you are asking because you have the symptoms like one-sided leg swelling, pain, warmth or redness, it's important to evaluate by a healthcare provider as soon as possible because DVT can be life-threatening if not treated. Okay, what is the treatment now? Absolute for exam or emergency department practice. Think of DVT treatment as confirm, then give anticoagulate, decide the duration, identify the special situations, intervene only in selected severe cases. Current international guidelines is broadly consistent. Anticoagulation is the main treatment, and DOAC are preferred. They for the drug of anticoagulants preferred for most uncomplicated proximal deep vein thrombosis. First, confirm the DVT. For suspected DVT, use the 2-level Wells score. Wells greater than 2 or equal to 2, then it is deep venous thrombosis likely. Proximal leg ultrasound urgently. If ultrasound is delayed, start interim therapeutic anticoagulation while awaiting imaging. Wells score less than 1, DVT unlikely, do D-dimers, positive ultrasound, negative DVT is unlikely and anticoagulation can generally be stopped. Before anticoagulation, do CBC, renal function test, liver function, PT and APTT. But if treatment is urgently indicated, don't delay anticoagulation while waiting for the results. Confirm proximal DVT anticoagulate. First line for the most patients, drug of choice anticoagulant. The two major options are apexaban, 10 mg per oral twice a day for 7 days, then 5 mg per oral twice a day BD daily. Rivaroxaban, 15 mg per oral twice a day for 21 days, then 20 mg per oral once a day. These are commonly used first line regimens, and NICE specifically recommended apexaban or rivaroxaban for confirmed proximal DVT in patients without important contraindication. Circumstances: important renal function, drug interaction, bleeding risk, body weight and special conditions must be considered before selecting the drug. Alternative anticoagulation: if apexaban or rivaroxaban are not suitable, then option number A, lower molecular weight heparin, dabigatran or edoxaban. Lower molecular weight heparin is given for at least 5 days followed by dabigatran or edoxaban. Option B, low molecular weight heparin or warfarin. Give lower molecular weight heparin together with the warfarin for at least 5 days until the INR is greater than 2.0 on 2 consecutive readings, then continue warfarin alone. How long do we treat? This is very important exam question. Provoke DVT. Example: DVT after surgery, trauma, immobilization or another transient major risk factor. Usually 3 months anticoagulation. For a provoked DVT due to major transient risk factor, for ESVS recommends 3 months rather than shorter treatment. After 3 months, if the provoking factors has resolved and the course was uncomplicated, anticoagulation can generally be stopped. Unprovoked DVT, this is obvious transient provoking factor. After the initial 3 months, assess risk of recurrence or versus risk of bleeding. If recurrence risk is high and bleeding risk is low, extended or indefinite anticoagulation may be appropriate. Cancer associated DVT. With active cancer, anticoagulation generally for 3 to 6 months. Consider drug of choice anticoagulants taking tumor site, drug interaction and bleeding risk into account. Lower molecular weight heparin is an alternative when a drug of anticoagulation is unsuitable. Special situation: antiphospholipid syndrome. This is a major exception to the usual drug of choice of anticoagulation first approach. In triple positive antiphospholipid syndrome, NICE recommends lower molecular weight heparin plus warfarin VKA initially with the lower molecular weight heparin continued until INR is therapeutic, followed by VKA alone. So remember, triple positive APS, think warfarin, not drug of anticoagulant. What about thrombolysis? Most DVTs do not need thrombolysis. Anticoagulation is sufficient for the vast majority. Consider catheter-directed thrombolysis or thrombectomy only in carefully selected patients, particularly those with extensive iliofemoral DVT. Severe symptoms: recent onset, low bleeding risk, good function status. The goal is rapidly restore venous blood flow and potentially reduce the severe post-thrombotic complications. NICE notes that extensive DVT can sometimes require catheter-directed thrombolysis or other endovascular treatment, but these approaches carry bleeding risk and are not routinely treatment. Inferior vena cava filter. An inferior vena cava filter is not routinely indicated. Think about it when acute DVT or pulmonary embolism plus absolute contraindication to anticoagulation. For example, a patient with acute DVT who has major active bleeding and therefore cannot receive anticoagulation. Once anticoagulation becomes possible, the need for the filter should be reassessed. Compression stocking and mobilization. Patient can generally be encouraged to mobilize early once adequately anticoagulated. Compression stockings are not routinely required to prevent post-thrombotic syndrome, although they may be useful for symptomatic relief of swelling in a selected patient. Emergency department approach. Remember this: if a patient comes to your emergency department with a swollen, painful leg, calculate Wells score. 2. DVT likely. Ultrasound urgently if delayed therapeutic anticoagulation while waiting. DVT confirmed, start anticoagulation. 4. Usually choose drug of anticoagulation, apixaban or rivaroxaban. Determine whether DVT is provoked or unprovoked. Provoked transient factors, usually 3 months. Unprovoked persistent risk, consider extended anticoagulation. Look for special situation: cancer, renal failure, pregnancy, triple positive APS, high bleeding risk, extreme body weight. 7. Consider intervention only for the selected extensive or iliofemoral DVT. High yield exam memory. DVT anticoagulation. Most uncomplicated proximal DVT, drug of anticoagulation. Provoked, then give for 3 months. Unprovoked, consider extended treatment. Cancer, usually 3 to 6 months, individualized. Triple positive APS, warfarin based therapy. Cannot anticoagulate, consider IVC filter. Most DVTs